And then next we have Bethany Howell from Links to Equity. She is the health policy analyst, and she has an awesome presentation on the cell and gene therapy access model. Hi, Bethany. Thank you for
Hi.
coming.
Thank you, Mariah, and thank you to Sickle for the opportunity to share today on the access model. We've heard from a lot of great presenters, and so I hope to add to the conversation by sharing about the model with you today. So what we'll do is kind of walk through from a broad and then funnel in approach. So I'll give a broad overview of the governing agencies and the key players involved with the access model, and then we'll move into how it is developed, how it's going to work, and then some key considerations. So I know we just have a short time, so we can go ahead and get started. Next slide, please. And the next one. Okay, perfect. So we'll begin by discussing CMS, the Center for Medicare and Medicaid Services. CMS is a federal agency that provides health coverage to millions of Americans through Medicare, Medicaid, and CHIP. So there are some key differences between the three different categories. Medicare is federal health insurance for people who are aged 65 or older, certain younger people with disabilities, and then also people with end-stage renal disease are eligible for Medicare. Medicaid's a little bit different. Those who are eligible are low-income adults, children, pregnant women, elderly adults, and people with disabilities. And then third, we have CHIP, which is the Children's Health Insurance Program. It's a federal program that provides low-cost health insurance to children from families who earn too much to qualify for Medicaid, but not enough to purchase private insurance. And also in some states, CHIP also covers women who are pregnant. Next slide, please. So next we'll talk about the Center for Medicaid and Medicare and Medicaid Innovation. CMMI, we'll refer to it as that for the rest of the presentation. So CMMI is part of the US Department of Health and Human Services, and CMS manages CMMI. So CMMI has authority under the Affordable Care Act, and the tasks that the goals they're tasked with are designing, implementing, and testing new healthcare payment models. The focus is on addressing growing concerns around the rising costs associated with healthcare, quality of care, and inefficient spending. The models facilitate the collection and analysis of innovation. So CMS monitors and collects data on the different models and how they're functioning, and the implementation of effective practices to develop necessary technology to support this activity. So really the ultimate goal of CMMI and the reason why it was designed is to help to create and monitor and provide better access to quality healthcare. Next slide. Okay, so we'll start with the brief history that leads us into how we got to the CGT, cell and gene therapy access model. So in October of 2022, the president issued an executive order on lowering prescription drug costs for Americans. There's been a lot of legislation that has been focused on prescription drug costs, and really this order said there's not enough being done, and what else can we do? So the order itself directs the Department of Health and Human Services to consider what other actions will drive down the cost of prescription medications. So in January of this year, the Health and Human Services published their response to that order. And that was a very detailed response that discussed a plan to develop a pricing model that supports the goal of driving down prescription drug costs. Next slide. Next slide, please. Okay, thanks. Oh, sorry, can we go back one? Thank you. Okay, so As you probably know, there are 2 currently FDA-approved gene therapies for the treatment of sickle cell disease. And on average, the costs of those therapies are millions of dollars. So between the 2 of them, they each range between $1 to $2 million, and that's per dose. Next slide. So the cell and gene therapy access model is designed with the outcomes-based arrangement plan. So there are a lot of programs that you may have heard of before, just referred to as differently. You may have heard of pay for performance programmed or value-based pricing. And really the goal of these arrangements is to allow manufacturers and CMS to negotiate directly with each other. And then payment is based on how well a therapeutic works. And we'll talk more about outcomes-based arrangements in the next few slides. Next slide. So outcomes-based arrangements really allow the payer to reduce the costs associated with prescription drug coverage that may or may not improve the health of their members. It's different from a lot of other models because there's the direct negotiation between CMS and the manufacturers. And rebate and discount levels are tied to a specified outcome in the target population. And that really functions as a money back guarantee. So purchasers are going to pay more for a drug when it works and less when it does not. And that's why the monitoring that CMS does is really important. So they'll be negotiating the terms with manufacturers in advance, and that sets the guidelines for how they determine if a particular treatment is helpful or not and how it should be paid for. Next slide. So I'll give a little bit of background on the cell and gene therapy model itself. The goal of the model is to increase beneficiary access to cell and gene therapies. So just like we talked about, those therapies are between $1 to $2 million per dose. And really this model will help to ensure access to that, but also reduce healthcare expenditures for everybody that's involved. And it was decided that sickle cell disease would be the first disease area of focus, which is really exciting. And so what the CGT model will do is create a framework for outcomes-based arrangements between states and pharmaceutical manufacturers. So it's important to talk about the key players. So who's going to be involved in the negotiation, who the beneficiaries are. So CMS will negotiate the terms of the outcomes-based agreements with the manufacturers. That includes pricing, so rebates, access standards, and outcome measures to be met. So just like I talked about, it's really important that CMS works closely with states to determine what the terms of the outcomes-based arrangement should be in advance, so that there's fair negotiation with the manufacturer and the pricing makes sense. As the model begins, CMS will collect data and then reconcile that data, monitor results, and evaluate the outcomes, and compare that to what the negotiated terms were of the outcomes-based agreement. Manufacturers are really important players as well. CMS will negotiate with them, but to be able to participate, a manufacturer has to have an FDA-approved therapy launched by May of this year. And they also have to participate in a Medicaid drug rebate program. So right now there's just the 2 FDA-approved gene therapies that we talked about in a previous slide. Any state is eligible to participate so long as they participate in Medicaid drug and rebate programs as well. The states will have an opportunity to submit a letter of intent, which really just indicates their intention to engage in the model. It's not a binding document. We'll talk about the letter of intent a little bit more, but the states have to be in Medicaid drug rebate programs, and CMS. So states and CMS can talk in the time frame. We'll go over a timeline as well between when the model now and when the model begins to ensure that this makes sense for the terms of the agreements make sense for each of the different states. States will also have the opportunity to apply for optional funding. So CMS will issue a notice of funding opportunity, likely in the summer. And then states who qualify can apply for additional funding to be able to participate in the model. Finally, beneficiaries, so individuals who are on Medicaid or Medicaid expansion CHIP. States will have the opportunity to separately negotiate with manufacturers for coverage of beneficiaries covered by the state's separate CHIP program. Next slide, please. So we'll go over a timeline really quickly. The CGT model is set to begin in January 2025 with a rolling start through January of the next year, 2026. And as of right now, the model will operate for approximately 11 years, but this all depends on the negotiated terms with the manufacturers for each state. So there are some key events to keep in mind, and these are broken down in the next slide. So there's a request for application to manufacturers. So their deadline is May of this year, May 2024. And then negotiations between CMS and manufacturers starts in May, and that goes until November of 2024. So that's when CMS is really working with manufacturers on the terms of the agreement and what is beneficial, what's most beneficial for the states. The state letter of intent to participate, the deadline for that is April of this year. And that's just an opportunity for states to indicate their intention to participate in the model. It's not binding. So if a state doesn't submit a letter of intent, it doesn't mean that they won't be eligible to participate in the model when it begins. State requests for applications and notice of funding opportunities are set to be released in the summer. And so we'll have more detail about what the terms of the funding opportunities are in the next couple of months. The deadline for states to reply to the state RFA to apply for the model is February of 2025, so February next year. States will begin signing their agreements in December of this year through June 2025. And again, the model starts January 2025, and it's a rolling start, so through January of 2026. Next slide. And I think we don't have a ton of time left. This is just the timeline, and it's broken down by category. So it has the deadlines for manufacturers, states, when this optional funding, so the notice of funding opportunity will be released and the timelines for that, and then the monitoring of the model performance. And we can go ahead and move past this slide. So there are some key considerations to think about as the model's being developed. We have some information, some official information from CMS that's been, or I'm sorry, from HHS that has been published, but there are a lot of lingering questions around the model itself. So one is for payment. So it's important to think about how will states pay for drugs. There are a lot of different types of payment systems for this. So we don't know if it will be upfront payment or fixed payments over a set amount of time, sometimes referred to as smoothing, or it could be something in between. It could be a combination of an initial payment and then fixed payments over time. We're not sure about that yet. Another important consideration is ancillary services. So we really want clarification on what services will be covered by the manufacturer and what services will be covered by the state. And if states are going to be able to provide additional services that are required for successful treatment. So thinking about things like transportation or other therapies that are involved while someone's undergoing a gene therapy treatment. It's also important to note that providers are not a formal list of participants in the model. There's really no discussion around how providers are involved, and it's important that they are involved because we want to ensure that they participate and that we get the data that we really need out of a model like this to make sure that it's effective. Next slide. Some other key considerations are that there's a sickle cell disease toolkit in development. The goal of that is to strengthen the infrastructure for care facilities and settings for people with sickle cell disease, improve care management, and assist providers in doing so. So we really want to understand how CMS will align this toolkit with the goals of the model. For beneficiaries, we know that separate CHIP enrollees are not automatically included, and we want to understand a bit better about how states will be encouraged or discouraged by the way the model is set up from including those beneficiaries. There are also regional differences in sickle cell disease populations, and we want to understand how that'll be managed. So the conversations between CMS and state Medicaid directors, how things will be taken into consideration for the model about that. There are also Medicaid fee-for-service versus managed care organizations. And we need to consider how states will ensure that managed care organizations aren't restricting access to treatment through the model. CMS has goals to use the data collection, and we want to know where any gaps might be, if those are good sources that they have. And then there's not a lot of information on the long-term follow-up. So we want to know how states will ensure that the follow-up for the model, monitoring of the data for the model continues, so that we have all of the important information on a long-term basis for the CGT model. Next slide. I think that's the last slide. Yes. Okay. So that's the end of our slide. That's the end of our presentation on the CGT model. I don't know if we have any time for any questions or comments from the chat, but I know the session's recorded and you'll have access to the deck that was presented that way. And also, if you have additional questions on the model, you can reach out to Sickle, and we can collaborate to talk about things in more detail that way.
Awesome. Thank you so much, Bethany.
Thank you. Thanks for having me.
Of course.